Three.
Hi, welcome to this evening's conversation with epidemiologist Glenn Grossman. I'm Rebecca Berman, thrilled to be moderating tonight's conversation. Welcome to May 2021. For those who are joining us live and those who are watching via YouTube, wanted to let you know we won't be recording on Mother's Day, but we look forward to joining again for a recording session the following Sunday. So we're thrilled to be back with esteemed epidemiologist Glenn Grossman this evening. As many of you know, Glenn Grossman has over 20 years of experience as an epidemiologist. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology forecasting and advanced analytics with Bristol Myers Squibb, Sanofi, Novartis, Medicare, Medicaid, Veterans Health Administration, Military Health Service, the CDC, and other programs within the United States and abroad. All views expressed today are his own. So as usual, Glenn, please give us a quick update about what's happening both here in the United States and abroad.
Thanks, Rebecca. All right, let me share my screen. All right, so here's where we are in the United States. You can see that there are a few key spots right now that are interesting. So New York and New Jersey, which were among the highest, have started dropping a little bit more. That can be seen over here. Whoops, let me put this up here. Nope. Over here. So New Jersey and let me actually just up here. So New Jersey had been getting higher, then we've been dropping rapidly. And like I say, I think this is largely seasonal. So we know that in the Northeast, at least, COVID has been following the typical cold and flu season. And so now we're leaving cold and flu season. We've had some great warm weather over the last few days. And so I think this is probably the primary driver of what's going on in New Jersey and New York right now. Michigan, I think they're dropping very rapidly too. It's probably due to the same type of thing. In addition, people have continued to get vaccinated in these places, so that's also almost certainly adding to these things. Interestingly, the curve in Michigan, you can see that Michigan started going up and then it came down and then went up again as a whole distinct surge. And so that's clearly based on the variants, the UK variant and others that are spreading, which again are more contagious and more severe, so sending people to the hospital more as well. But UK variant is we are protected with the vaccine. The vaccine does protect from the UK variant extraordinarily well. It's some of these others that we're talking about that it's not quite as effective. Now, one of the problems that we're seeing, or that we saw last year in the summer, was that we saw this second surge that appeared that were in different states. So the Northeast surge and other parts of the country were the typical cold and flu season, and then it ended by June or so, May, June. But if you notice, around the June timeframe, the South started getting hit really hard. And so it's still undetermined what the South is going to look like this year. This is a big open question. The two schools of thought right now, one school of thought is that because of vaccines, this is going to disappear this year, that we won't have any new surge in the summer anywhere in the country because of the vaccines. There might be some infections, but not really any excess hospitalizations or deaths. That's one school of thought. The other school of thought is that the variants are spreading more. And last year, the South didn't get hit very hard during the first surge when a lot of the rest of the country did. And so the second school of thought is saying, well, the variants are going to continue spreading, and the same risk factors that drove the second surge in the South and the West, but primarily the South last year, might drive another surge in the South this year, despite the vaccines. So that's a different school of thought. We don't know yet what's going to happen. So it's going to be a really interesting real world test to see which of these schools of thought are right. My personal thinking is that we are expecting that the vaccines will be effective. So I don't expect a surge nearly as high. However, we don't know yet. And it's interesting because it will be a test for what our winter will look like, our fall and winter, because if there's a second surge, despite the vaccines in the summer in the South, then that means that our vaccine shields are not as strong as we were hoping, and we will likely see another big spike in another surge come fall, winter in the Northeast and the rest of the country. So, so a lot of eyes are looking at the summer. The reason that a lot of us are looking at this now is here. As we've been talking about before, so here's South America and Brazil. Brazil, Southern Hemisphere, so they should be flipped. So they're so when it's summer here, it's their winter. When it's winter up here in the Northern Hemisphere, it's their summer. And so if COVID is really reflecting a typical cold flu season type of thing, then that means that when it is summer here, they should be higher. And so we should be seeing these surges that go up and down. But in contrast with Brazil, you can see it just started big, it went down a little bit, and it just kept on going big ever since November. That's their summertime. That's not their winter, that's their summer. So something strange is going on. And we know what it is. It's the variant that's the new variants that have emerged there are reinfecting a ton of people. And now it's not only in Brazil, it's spread to the rest of South America. So we're seeing the rest of that same behavior there. When you look at India, that's what we're seeing in India as well. In fact, let me look at this map. This is I like referring to this map a lot. When you see there's a few countries that are really the darkest red, the very dark red today, right now, the only one looks like Uruguay. But much of South America you can see is dark red. So not the darkest color, but very dark. This is so unusual because it's the Southern Hemisphere. So they are just entering their fall season. So we're in our spring. They're entering their fall, but it's still early. But this has been like this for weeks. I mean, Brazil, you just saw what I showed you. It's so odd. So COVID is not reacting the way that we expected, and it's reinfecting a lot of people who had been naturally infected. It's a demonstration that herd immunity is not observed in the Southern Hemisphere from people who are naturally infected, because the number of people that were previously naturally infected should have generated herd immunity in many of these places, and yet you see it's on fire right now. Same thing for India. You look at how dark it is there. The rate is 268.8 out of 1,000 per million, which is quite high relative to much of the world. They too also a lot of reinfections, because they also had achieved in many places what they thought was herd immunity. But now that they're all the infections we're seeing there now, a lot of them are reinfections. And so that means, again, a demonstration that this concept of herd immunity from natural infection does not appear to be working. It's not unexpected. So I mentioned, I think last week, and I've talked to other people over the last year or two, or year and a half, that the flu of 1918, sometimes called the Spanish flu, the big pandemic, that infected a huge portion of the world. I think maybe a third of the people in the world had symptoms, or something enormous. I don't remember this off the top of my head, but we never achieved herd immunity from that virus. So to the point that every flu after that, every flu season after that has had a spread of variants from that original flu pandemic. And so anything that's in the form H1N1, so if it's H something N something, like H2N3, anything in that form is actually just another variant of the original flu of 1918. So whenever you hear in the news, or we've heard over the last 10, 20 years about avian flu or swine flu or all these, those are all just continuing variants. We've never achieved herd immunity of the flu of 1918. So it's really skeptical. The other major reason that we're skeptical is there are 4 other common variants in circulation that just cause the common cold. They don't cause severe disease or hospitalization. And so because of that, and they're also asymptomatic. So because of that, they've had free reign to just replicate throughout the world as much as they want. And so theoretically, if they had, they would have just burnt themselves out. And so there would be herd immunity because they just infected everyone, because people didn't even know they were transmitting it to people because the symptoms were so weak. And yet with those four very common cold viruses, we've had colds for many years. There's no herd immunity to the cold virus. It's been with us for a while, and there's no herd immunity with all these other coronaviruses. So it's right now, a lot of epidemiologists are very skeptical of the idea that herd immunity is even possible. And what we think is that Fauci is just bringing the population on a journey to come to a place where at first he said, oh, herd immunity might be at 50%, then it's probably closer to 70% or 80%. And at some point he'll bring us further on the journey and say, well, we didn't get enough people vaccinated and the variants have gone too far and there's too much mutation around the world. And so herd immunity isn't possible, but with vaccinations and perhaps continued vaccinations, similar to the flu, how we deal with the variants every year there, if we have new vaccinations for COVID with some of these new vaccines, then maybe that will reduce to a very low level severe illness, hospitalizations, and mortality, and then it will essentially be just another common cold. And so I think that's what the goal that we're all shooting for in the epidemiology field. This is the world picture right now. Let me go back one more time to the chart. So if we just look at the world, you can see, so it's a little bit hard to see, but you can see that the world as a whole has had two major surges. You see that there was an uptick in March, April of last year, but there were a lot of shutdowns. So we got it to an extent under control in a lot of places around the world. Then by the summer of last year, it was still starting to increase. By November, it really hit much of the world hard. And then it started going down. But now you see that we're in May and we're in a new surge. And this is largely, again, driven by India, Brazil, and some of these other countries. And so the world there's a lot of variants that are just exploding around the world now. We don't even know. We might not even hear for weeks or months about some of these new variants. It could be the case that a new variant that ends up hitting us in the United States in the fall or winter of this year is from variants that we haven't even become aware of yet. Maybe they're in the world circulating already, but we don't even know about them yet because they haven't even been identified. They're not getting a lot of people sick yet. So we'll see. Like I said, the big test is going to be this summer, looking at the South in the United States, because that's going to tell us a lot about how the variants behave off season and what the fall and winter will look like for us. Was there anything? Oh yes, vaccines. So let me jump to vaccines real quickly. So here's where we are with vaccines. So among people over the age of 65, which is a proxy for people at high risk for severe illness and mortality, 83% have gotten at least one dose. Only 69% are fully vaccinated. What we're finding are that there are millions of people, maybe several million, who have not gone back for their second dose yet. And this is problematic. The first dose does provide a fair amount of protection, but we really need to get people their second doses. This is one of the key reasons why the Johnson & Johnson vaccine, I think, is still going to play a really important role, even though it has a little bit less efficacy and it's similar safety. Even though there was the safety scare, it's nothing to be scared about. They did their review and found that the risk was not anything to be scared about of anything. So the benefit of the Johnson & Johnson vaccine is it's one dose, and so if all these people are not coming back, then if you're comparing one dose of an mRNA vaccine versus one dose of Johnson & Johnson, the one dose of Johnson & Johnson on that comparison is better. Even with the second dose of mRNA, the Johnson & Johnson compares very favorably. But because a lot of people are only getting a single dose, if that's the case and they're at risk of only getting a single dose, then probably the Johnson & Johnson is the better choice. One other thing I just wanted to point out, I don't know if you can see my screen. this is herbal tea that I'm drinking. I don't know if you're like me, but I'm trying to shed some of the weight I put on over COVID year. So this is not wine that I'm drinking right now, but it is herbal tea, which I'm drinking right now.
Yeah, right. Whatever. We believe you. That's
No, I
okay.
am.
Drink
I've
whatever
been,
you.
in fact, there have been some questions. I think maybe I was talking more about it next week in terms
About
of,
your herbal tea?
no, and
Oh,
well, there's questions always about that, but in terms about weight gain, which is a separate epidemic now that we almost have to talk about it, just because it's been associated with so many illnesses, and a lot of people across the world have put on weight over the last year, way more than historical, in history, or at least in recent history, in a single year. And so the question will be, will we lose it? What's going to happen? This is an issue. And so people have asked questions, so I can bring some of that up next week. Anyway, the other thing here is people over the age of 18. So for severe illness, it looks like we're doing a better job of vaccinating, even though a lot of people aren't getting their second dose. This is better than a typical, the percentage that get flu vaccine every year. A typical year, the order of magnitude that I think of is typically around 65% get the flu vaccine every year, who are age 65 or over. And so that's a pretty high number. It's much lower among people under the age of 65. And so we're clearly doing better for COVID-19 vaccination here. For people over the age of 18, that's a better number than typical flu vaccine year, but it's not good enough for any to slow the virus down sufficiently for what we're looking at. There is a lot of variation by state. So let me look at this some. You can see that some states are, let me look at people. So some states are doing particularly well, like look at the Northeast up here. Some states are not doing quite as well. So for instance, the South is lighter green than the, let me see what it is. It's a lighter green than some of these others. And so that again, like this test I was just telling you, the hypothesis about what the South is going to look like in the summer, that's going to be really important. It's going to really tell us some interesting things for what to look out for in the fall and winter. And with that let me talk about global one more time. Here, there are two more things. So here's the US snapshot. There's 4 states right now, 5 states that are really the hotspots that are going down, but they're still kind of the hotspots. And so the states that we're looking at are Colorado, Minnesota, Michigan, Pennsylvania, and Rhode Island. And so they're not, you can see we're not out of the woods yet. So the numbers are going down in a lot of these. So I can show you what we just saw here. Like Michigan, you can see that it's still going down. So that's good that the direction is right, but the levels, the magnitude is still so high that they're not out of the woods. This could turn if they let their guard down, if new variants start to spread. So we're not out of the woods. Pennsylvania, let me look at Pennsylvania real quickly. Oops. Pennsylvania is coming down too, and I think in most places, I was looking earlier to try to see if there's any that are going up currently. I think pretty much everywhere it's going down, and that should be reflected up here when we look here. Yeah, so we're starting to go down at the net average everywhere in the United States, as we were expecting because of the seasonal variation that we're looking at. And when you look at the death rate, that's even faster because of the vaccines. So let me click to that. Or actually, it's the same graph. Deaths. And so you can see that we're going down. We're not going down as quickly as we would like, but we are still going down in that direction. And I don't know why we're not going down as quickly. I suspect that we've gotten really good at keeping people alive in the hospital, and so there's more of a delayed effect for some of these deaths, I think, now that we're looking at. Anyway, all right, Rebecca, let's open it up to questions.
All right. So Glenn, quickly, the authorization level is still at emergency use authorization for our vaccines, right? So when do you anticipate that the vaccines will be fully approved at regular standard approval level from the FDA?
Yeah, that's a really good question. Here, let me open this up. Let me see.
And might that impact the vaccine hesitancy?
yeah, no, I can't pull this up quickly. So essentially, I as quickly as possible. The key issue, the reason why they haven't been gotten full approval yet, is that typically we want to have a longer period of time to observe the results to ensure safety and efficacy. In modern epidemiology and statistics, what you typically do is, actually, this is an interesting discussion. So we typically would do a Bayesian analysis for a lot of these analytics. And you could ask the question, given the results so far, based on how safe the vaccines have demonstrated themselves to be and how effective the vaccines have demonstrated them to be, both in the clinical trials and in real world data, what is the likelihood that further observation for more months will fail to prove that they're safe and effective? That something will happen that they're so bad that it will not be approved. And if you do that analysis, then you wouldn't expect anything, because we've been following these people long enough that the amount of safety incidents and effectiveness incidents that would need to happen to bring the average down from what we've seen so far would be extremely unlikely. This is called a Bayesian analysis. The problem is smart epidemiologists use Bayesian analytics all the time because we understand it, we're comfortable with it, it's good. The FDA has only recently started to become more comfortable with Bayesian analytics, and they prefer what's called frequentist analytics. Frequentist analytics or frequentist statistics are what you would have learned in high school or college. So the typical standard type of statistics, that's all frequentist analytics or frequentist statistics. And so the FDA has had these great processes and protocols in place for decades. And so they are very conservative and very risk averse, which is good. We want an FDA that's risk averse. And so they've been very slow to adopt some of these new techniques. They started adopting them more in devices and stuff, some of those things at first, because they thought that the risk of getting it wrong was a little bit less for devices rather than for other types of therapeutics. But I think that they've slowly started to shift and to be willing to apply this kind of thinking for therapeutics as well. However, right now, I think that we're probably, I think, within weeks, maybe months, going to have the process, the way that it's going to need to work is that the vaccine companies need to submit an actual application. So they actually have to fill in paperwork and show all the results again in a new template for full authorization to get approval. And then the FDA typically has only two approaches to dealing with that. One is the regular approach, and one is sort of a speedier approach. The problem is the speedier approach is still pretty slow. So we're all hoping that the FDA will have sort of this really new approach, that because of the epidemic, that they'll be even faster than the previous fast that they were used to, which I think was 3 to 6 months or something was the previous fast. The reason is that once there is full approval for the vaccines, or for anything, frankly, because everything right now is, I think, emergency use authorization. So, and by that I mean the monoclonal antibodies, even the diagnostic tests are still emergency use authorization. Typically, the diagnostic tests themselves would have to go through formal approval procedures to get formal approval. But I think the tests even that we're giving are all EUA, or emergency use authorizations. So as far as I can tell, I can double check on that. But like I said, so they're going to have to go. The benefit of going through full approval in it is that two benefits, I would think. One is that I think that might help to combat the hesitancy that you mentioned, the vaccine hesitancy. If people see that it's gone through full approval, maybe it will hit some of those people. I don't know how big an impact that's going to have, because some of these people who are hesitant, I think, are just scientific illiterate. And so I think we need different strategies that we might need to look at, but it might have some effectiveness with them. The second thing is that the government, I think, or businesses can sort of be more assertive in requiring vaccinations. If it's only an emergency use authorization, maybe it wouldn't be something we could require. However, once it becomes fully approved, then maybe there are legal dynamics that might change, where the federal government could then put further assert its power to have requirements. If not the government, maybe businesses or other organizations. But that dynamic changes a little bit. So those are the key
All
things.
right, more to come. How about any updates on 12 to 16-year-olds, the approval for that age group on the
Yeah.
emergency use authorization?
No, so we saw early great results for that. I don't know if I have a slide here, but we do. I think I'm personally expecting within the next few weeks. I haven't heard anything yet of a date that's scheduled, but I'm assuming it's going to happen sometime soon. But I don't know.
And that will also be a 2-dose
That will
regimen
also
you
be a
anticipate.
dose regimen. That's right. That's right. It's essentially the reason that we did adults first is that every drug, every vaccine and drug that's out there is always a risk benefit balance. And so the benefit of the drug is greater for people who are at risk of more severe disease. The risk of the drug or the risk of the vaccine has a better balance ratio because of that. So if the benefit is really high, then even if there's a low risk, or a medium risk, let's say, it would still be better to get the vaccine if the benefit is so good. As you get to younger and younger ages, because the disease is, first of all, the risk of infection is much lower. And second of all, the risk of severe disease, if you are infected as a kid, is much lower. Then that means that the severity of the disease was, that the benefit rather of the vaccine is lower because it's not really protecting as much, but the risk might be the same. And so that means the risk benefit might change. So that's really what they're looking at here. The risk we found out across the population, across the 16 and over crowd, is so minuscule, particularly among the mRNA vaccines, but essentially among all the vaccines that have received EUAs in the United States, that we're fully expecting that as you go down to the kids, we're going to see the same type of thing. In fact, I think I believe they're looking at much younger kids now in terms of some that they're investigating. So that'll be good news. The flu, the typical flu season, even though COVID-19 is far, far different than typical flu, COVID-19, or rather the flu, frequently is the people most at risk are the very old and the very young, like people like kids under the age of 6 months or so. And so we haven't really seen that risk for COVID-19 in that population. But so that's something that we're going to be looking at as well in terms of the vaccines eventually and that kind of stuff.
Okay, thank you. More to come. All right, so you just told us about the vaccines, you took us around the world, you touched upon India. Can you take us a little bit deeper into what is going on in India?
Yeah,
I thought they were near herd immunity. Why are the infections and death rates skyrocketing? Could you be a little bit more specific, please?
Yeah, let me share. All right, so here are some images. This was from USA Today. What our best estimate right now is, so there's a major scandal. In addition to the major crisis going on, the government of India has been putting pressure on the hospitals around the country to sort of fudge the data. And so this has become a major scandal. Local news organizations in India or around India have been writing about this now for a while now. And so, for instance, maybe 90% of the deaths from COVID are not listed as COVID deaths. And so you have all of these bodies piling up, that you see these massive burnings of the bodies that are piling up that are not consistent with the numbers that are being reported on the websites that we show. So for instance, when I was sharing this with you a little earlier, let me bring this up here. Oh, where was I? This one. When I was sharing this with you, here's India. Whoops. I don't know why India's not hiding. Let me just try refreshing this for 1 second. So India, when you look at the charts here, you see that that it doesn't look so bad compared to the rest of the world. So for instance, here's the United States, And India is not so bad as a percentage of the population relative to that. When you look at this, this is right now in terms of cases. If we look at deaths, so in terms of what's being reported, here's the United States and here's India. They look very similar. But like I said, so some news organizations have gone in and actually looked at the hospital records of some examples, and they found that only 10% of the deaths, so the deaths that are reported on the screen that we're looking at, represent only 10% likely, maybe a little bit more, but roughly order of magnitude 10% likely of the true deaths, the magnitude of the toll that they're hitting. So they are being slammed really hard. The data is being fudged, and so it's hard to know exactly what's going on. They're not doing very good sequencing of the genetics, so we don't really know what the variants are that are spreading very much. We know that the UK variant is spreading some there, and the India variants are spreading some. And so that is something that we're keeping an eye on. Let me come up here. Oh, and let me show some of these other images just to show the disparity between the images and the numbers, why we sometimes have to be skeptical of the data that people report. So the number of mass graves and burnings are just impossible for us outside of India to even perceive at this point. Anyway, I put this slide together in terms of talking about the India variant. So maybe let me switch to that real quickly, if I can find it real fast. All right, so the India variant, first let's talk about here. So in India, it's hitting India across the country. Some places in India are being hit harder, and like I mentioned earlier, it's a lot of reinfections because the places that are being hit harder were already hit really hard. And so there is no way to get to see the numbers we're seeing without a large number of reinfections. However, because the diagnosis rates were so abysmally poor in India, the data of reinfections is poor, and so we can't even. There's not really good data to even tell us. But we wouldn't be getting these numbers without reinfections because it's just the population size wouldn't support it. As big as India is, it wouldn't support it. The other thing that we're talking about is the India variant, and there's actually more than one India variant. But basically, the question there is what we've talked about is sort of a double mutant, that there's different mutations. Let me see if I can bring up something we talked about last week. So basically, there are different mutations. Here's the India variant. It's called B1617. There's now more than one variant in India that's spreading, but they both have the same type of issue. The main issue are these two things. These are the spike mutations that have occurred, and there's two that have occurred. In other mutations that we've seen, we've talked about earlier, it's been the E484K, and it's at the site 484. And remember, if I bring back to your memory, the interpretation of this name is that at site 484 it was E and it's mutated to K, so it's shifted. It's the mutation is changed, and so that means any gene that you see here that we're looking at, the name of the mutation, that's the interpretation. So this one is at 452, site 452. It's gone from L to R. Now, these are the two sites that we found to be most important. E switching to K at 484 and L switching to R at 452. And the reason they're important is because it makes for two reasons. One, it makes the virus, it seems to be a little bit more contagious. And two, it seems to make it more resistant to the vaccines. And so, although there's other things that are responsible for the vaccine resistance as well. Okay, but you'll notice in South Africa and Brazil, which are a little resistant to vaccines, look there's what we see, the E484K, E484K, and here's Brazil again. In California, this is there is a more contagious strain that's been going on there. That's again the L452R. In India, it's being called a double mutant because it has both the site 484, and instead of switching to the K, it's gone from E to Q. But then it also, like California, has the 452 site going from L to R. It's kind of a misnomer to call it a dual mutant because there's actually numerous mutants that are occurring. The two here are unique because they're in the spike part of the virus, and so that is why they're unique. We're still waiting. We don't have a lot of good data. I've seen some chat on some of my epidemiology listservs that I'm on, that they think that that there's a question about whether the mRNA vaccines might be more or less effective versus the vaccines that are common use in India, which are not the mRNA vaccines. And they think that the ones currently in common use might be more effective. But again, we still don't have data. So I am keeping an eye on this. But because obviously when this starts spreading in the United States, we're going to want to know how effective our vaccines are going to be about it. Right now, you see a lot of gray areas. There's still a lot of unknowns about how well our vaccines are doing on this. So we'll keep a lookout, but we don't know. Going back to what I was just saying for India now, let me just come back for a second before we close this question out. And that was up here, I think. Oh, wherever. I've talked enough about it.
I think you went right past it. There it is.
Did I? Oh, is it over here?
Yes.
There
Yep.
it is. All right. So the one other thing I think was just here about whether it's a double a dual mutant or not. So yeah, there's the key thing coming out of India is that the scandal is just as big as the epidemic, that they're fudging the data. You can't address what you can't see and what you're not monitoring. And so as bad as it is, if we had better intel about what vaccines are working, maybe we could donate different vaccines if different vaccines work better, for instance, or better treatments. We're just there's a fog of war thing going on, but it's not just a fog of war. They're really manipulating the data and fudging it. And so that's really problematic. All right, Rebecca, let's go on to some more questions. There's a lot of questions.
Thank you, Glenn. Okay, so thank you for letting us know more about what's going on in India. Okay, so let's move on to the question about masks. How do we know that masks are in fact effective? And thank you to Mark for asking this question.
Yeah, I apologize for punting on this for a few weeks, but I wanted to compile the sum of evidence that we know, and I'll try to go through this somewhat quickly. There's quite a lot, but there's basically 3 or 4 different sources of evidence that we have here. One is the idea of masks in other viruses. So for instance, in SARS, MERS, flu, etc. So how well do masks prevent that? Another is from animal studies, because you can't purposely expose humans because it's unethical to potentially make people sick or have a severe or deadly illness. But you can do that for other animals. And so there's animal studies where they put the masks up, and I can go through those briefly. We can look at studies that have looked at mask mandates to compare countries with mask mandates versus countries without mask mandates, and to see what impact that had, and then to compare states with mask mandates versus states without mask mandates, to see what impact that's had. And I think we'll go through, but I think those are the major sources of evidence right now. The very first thing I wanted to just quickly go through is, for a while, there was a debate about whether COVID-19 was primarily spread by aerosols. And this is still an ongoing debate. Most epidemiologists, I believe at this point, including me, are convinced that it's primarily the aerosols that are driving the spread of this of COVID-19 globally. And there's 10 sources of evidence here that I'll go through quickly. But the biggest one for me is that you can't really get super spreader events unless you have aerosols. We know at this point that there's not really any evidential support that it's being spread by hands. Like, so for instance, people touching doorknobs or other kinds of things. So it is respiratory. And so then the question is if it's either a droplet or aerosol. An aerosol, again, is really microscopic droplets. They're not even considered droplets at that point. That can just float around in the air, almost like dust, and they can literally stay in the air for hours. So someone with COVID-19 could go into a room, be there for a couple of hours, leave. Someone else could go into the same room, not even know that the person was in there before and could be infected because they were in there, and the aerosol remained floating for a few hours after, at least. All right, so first is the super spreading thing I talked about. Second is long range transmission. So long range transmission has been demonstrated in adjacent rooms using the same ventilation systems, but and that's been demonstrated at this point for SARS-CoV-2. That wouldn't be possible through any other mechanism, essentially. Fourth is transmission of SARS-CoV-2 is much higher indoors than outdoors. If it was just transmitted by spit, you wouldn't really expect there to be a huge difference indoors versus outdoors. Third over here was coughing and sneezing. When they've done surveys and things of people transmitting it, and they've done contact tracing, you can see whether coughing or sneezing was in place. And for this percentage, it was not, which means aerosols are likely. Fifth, nosocomial infections, so community spread, where they've had strict precautions that were designed to protect against droplet but not aerosol exposure, have had spread. And so clearly the PPEs weren't working when it was just protecting against droplets but not aerosols. The last one here is that it's been detected in the air as aerosols. Let me just go through a few more just because I think people might be interested in the evidence for this as well about the aerosols. Seventh, it's been identified in air filters. So for instance, people have air conditioning systems and heating systems that have filters in them. If you go and just collect those filters, which are a distance away from the ventilation ducts and everything, if you collect those air filters, that's been found in a bunch of businesses at this point, the aerosol there. Eighth, infected cage animals that we'll get into in a bit, but yes, they've demonstrated that caged animals at a distance can get infected. Ninth, no study has provided strong or consistent evidence of other sources of spread. So for instance, spread, like I said, on the doorknobs, and spread through spit through spit being spit out, there's no evidence for that right now. So the lack of evidence for aerosols doesn't mean that that's strong evidence for spit or for other things, because we don't actually have evidence for spit either. And then finally, 10th, there's limited evidence to support other dominant routes of transmission. So again, this is what I've just said. So this is the key thing. So now based on this sum of evidence, most epidemiologists, I would think at this point, are convinced that aerosol is the primary spread for COVID-19. If aerosols are the spread, then now we jump into the mask discussion. How well do the masks prevent the spread there? All right, let me jump in. So the first one was looking at flu. And this was first published back in April of 2020. And so this was looking in flu with 3 different kinds of filters, and they found a significant decrease in looking at leakage of air, that despite leakage, penetration, whatever, it was a significant decrease in aerosols that were able to penetrate. So even though they weren't perfect, you could see a dramatic impact. And so this was more of just like physically looking at the mask itself and seeing what was coming through. Next I'm going to skip over this one. Next, let me talk about the hamster study, because this is a cool study. So what they did is they put lots of hamster cages together. The first thing they did was they isolated them. They put them in the cages. They separated them so that some were fully exposed to the same air. Some had a filter. So rather than putting masks on the animals, that would have been too tricky. What they did was they put a separator between all the cages, and on the separator, they put the mask material. So it was as if they were masked. And so they did this in 2 different ways. One, they put the mask near the hamster that was infected. And then 2, they put the mask near the hamsters that were uninfected to see whether wearing a mask among the infected people was more important versus wearing a mask among the uninfected people to prevent was more important. And I say people deliberately because, again, here we're using the animal, the hamster, as a proxy for what we would expect would happen in people, because they have the same ACE2 receptors and can be infected in the same way that we can be infected. So it's a really good model that we're looking at. So this is the picture. I'll go to the next screen. So essentially, based on what I just said, this is what we're looking at. They color-coded the hamsters here. So basically what we have here are the SARS-CoV-2, the index hamster is the one that was infected, purposely infected. Then you have these they were sacrificed as a nice way of saying that they were killed to see if they were infected. Some were done at 5 days, some at 7 days. Essentially, what they did after this was this was experiment 1. There was no surgical mask in the partition. So you had the one that was originally purposely infected, seeing if they infected the other the other ones that were uninfected without a mask. Then that was sort of like a control. Then they repeated this experiment in 2 more times. The second experiment they put the mask on the cage of the one that was purposely infected. So then the uninfected ones had no mask, but the infected one did have a mask, and they wanted to see what impact that had. Then the third experiment was looking at the other way. So the mask here was on the people who were uninfected, but the infected person, the infected animal, which is a proxy for the person, did not have a mask. The reason this is important is for asymptomatic spread in people. One of the most important reasons that we think at this point, in part because of this study, but also because of the others that we'll talk about in a second, one of the most important things is for asymptomatic or pre-symptomatic people who don't know that they have an infection, for them to wear the mask protects people to a greater degree than the uninfected. And in fact, let me actually be talking about this on the results page, because that'll be easier to see. And so that's one of the biggest benefits that came out of the study. You'll notice here, naive, they had there was a 66% chance of getting the infection if there was no mask. If there was any mask, it was a 25% risk. Among the ones where the infected animal was masked, so that would be asymptomatic, pre-symptomatic, or symptomatic people, it reduced it to only 16% spread. Whereas if you put the mask on the uninfected people, so the one that was previously infected had no mask, so the asymptomatic people walking around, no mask, but you only had the uninfected people wearing the mask, then you see a third of them still got infected. And this is why I've been saying a lot over the last year that masks are not as effective as we hope they are. They're not 100% effective. They're not this universal shield. They are amazingly great. And clearly we need to have almost as many people wearing the mask as possible, because it's specifically the asymptomatic, pre-symptomatic people where it's most effective. No one knows who's asymptomatic or pre-symptomatic, that they're infected or might have been infected. And those are specifically the people that need to be wearing the mask. That's why everyone should be wearing the mask and why it's so critical that we do so. But people who wear the mask and are uninfected, really it's not as strong a protection as it is if you get the people wearing masks who are the ones who are ultimately infecting the other people. So this is a really good source of evidence, because it is under clinical conditions where you can literally adjust every little parameter to see and tweak things and see what might happen. So a lot of people are pointing to this study as a really good study because of that. However, animals are not people. And so that's why some of these other studies are really also important. So let me just spend just a few more minutes going through some of these. All right, so this right here that we're looking at was published in Lancet, which is a really prestigious medical journal. Hard to see on the screen here, but this is looking at SARS, MERS, COVID-19. So all the coronaviruses, but very similar, cousins to each other. Looking at all of these across different countries in the world. The average there was when you wear masks, so they were looking at events with a face mask on versus events with no face mask on. And when you do this comparison, you find that it reduces by 70% the total number of infections when the face masks are worn. So this is also really, really important evidence. In non-healthcare settings, if in healthcare settings, you can imagine, this is healthcare settings. Healthcare settings, they're more on top of things. They wear masks. They're much more deliberate in the mask using, and so the 70% is probably a ceiling in that sense. Under real world conditions where it's a non-healthcare setting, it's more like 45%, which is great in terms of not wearing it, but it's not as good as we would like to think. That's why I've been continuing to say over the last year, it's not just mask wearing. We should be spending as much time outdoors if we want to be with other people as possible, because indoors is much higher risk than outdoors, and the social distancing continues to be important. Now that more people are vaccinated, again, we see that people who are vaccinated can still get infected and can still have severe symptoms and can still die. And so as a result, the mask wearing and things still become important. But again, the mask wearing is not a perfect strategy here. But let me go on and just show a few others, because so it's complete in terms of all our sum of evidence here to date. Here that we're looking at are respirators versus surgical face masks. And you see that these are more effective. So this is 96% effective if you wore a respirator, as you would expect, which really eliminates all the aerosols. The surgical face mask is what is this, 85% effective. So there is variation in the type of mask. We have talked about that previously. However, in real world settings, that's not a hospital setting, a lot of people just don't wear their masks right. So I wouldn't interpret some of the studies. I would interpret it closer probably to like maybe 40% efficacy, 50%. However, having said that, let me jump now to this study. So this set of studies are the ones looking at the mask mandates. Here we're looking at Italy and New York City. You can see there was a really strong trend line in terms of the total number of people that were getting infected each day in Italy and in New York City. Once the mask mandates came in, and that's this vertical gray bar, you can see the predicted line where it matched really strongly, deviated very fast from the masks after the mask mandates went in. Now, the other thing is the mask mandates did correspond with some of these other mandates. Some of them happened at the same time. So it's hard to surgically separate mask mandate from some of these others. I didn't go through the effort of doing that in this exercise here, but this is seen in terms of, this was published in PNAS, the Proceedings of the National Academy of Sciences, which is also a very prestigious journal. And this was looking at airborne transmission and was looking at masks and as the interpretation for a lot of these. The one other thing here is this was looking at state by state. So states that had mandates for masks, and that's the thing, is a lot of states had mandates for masks, but didn't really have the mandates in place for other things. And when you look at the states that had, let me just reread this real quickly. So this was employee only face masks during working time. So when you looked at organizations that required employees to wear face masks, this was before the trend going up, and then this was the reference period going down. You see that beginning 21 days, there's a clear trend. It looks like it's not statistically significant here for among the employees, but you see that there's a clear trend that it starts to go down and that it becomes much less after the mask mandate. In this one, it's much clearer. This one is community face mask. So in public, when there's a community, you can see that before the reference period, they're all roughly the same infection rates. As soon as the reference period, again, this is when the mask mandate's put in place, you see a pretty rapid and increasing impact, that the masks have this massive impact, that there's less spread very rapidly by 21 days, and it continues to go down. So this basically represents the tapestry of our sum of evidence for masks. There are some other studies out there. There's one more, I think I skipped it up here. Yes, so this was looking at this one over here. So now this was looking at the inoculation dose. This was just one other question that comes up. So one thing that we saw, and this also became apparent with the hamster trials that I just mentioned, was that one of the things the masks do, and not just the hamster trials, this was all of them that were looking at aerosols at even a physical level. Like, so for instance, this one, looking at the number of simple particles that were making their way through. One of the things that we realized from other studies is that the inoculation dose makes a big difference. And by that, what I mean is that the number of virus particles that a person initially gets exposed to has an enormous impact on the likelihood that that person gets severe disease. So that's huge. The higher, again, the more virus that a person gets exposed to when they're first exposed, the immune system thinks it needs to respond much stronger because more virus came in And so as a result, the immune system really struggles and really drives up very fast. And that's what causes these severe symptoms. And so the higher the dose, the bigger the immune system reacts to it. So that one of the benefits of the mask is because it reduces, even if some of the virus particles get through, and you see that it's not 100% effective in what I was mentioning, that it's only partially effective. The thing is that even in the partially effective people, it reduces this inoculation dose. It reduces the number of virus particles that get through. So as a result, you expect less severe disease. And so a lot of modeling and a lot of investigation has taken place looking at the impact of how effective the masks are in terms of reducing severity of disease if a person is infected despite wearing a mask. And so all of these things together come together, and that's where some of evidence is. That's why every epidemiologist out there and public health worker says, wear the mask. There's no controversy there in the epidemiology community. There is variation. So if you're asking for a specific number, are masks 80% effective or 50% effective? There's variation. We don't know for sure yet. I showed you some of the ranges and some of the sources of evidence that we have there, but that's where we are. Do you have follow-up questions on this, or is this sufficient for now?
Mark, does that answer your question?
Yeah, that was so informative. Thank you. It seems like a lot of people make this big deal out of, well, they have to be peer reviewed, but my goodness, that seems like pretty strong evidence.
Yeah, and frankly, these it's extremely strong. And these journals are not not small journals. Clinical Infectious Diseases, prominent journal, like these are all really important journals. And so and now at this point they've been peer reviewed. It took a while, and so it's not that they were just not peer reviewed at all. It was just the peer review process took time, and so now they've gone through that process.
Thank you.
All right, Rebecca, we have,
Okay.
so I started a little bit late. Let's go through a few more questions.
All
I'll speak much quicker.
All right, absolutely. Thank you for that great question, Mark. Glenn, thank you for that very informative answer. And of course, your graphics are always just so terrific. Those little
Like
hamsters. Look at those hamsters.
They're so cute.
They really are cute. So thank you for sharing. Yes, that one.
This I can't take credit. This is the author of the article.
You shared it with us, and
Yeah.
that says it all right there. That just says it all. All right, so Glenn, we had a lot of really good questions come in this week. You prepared a lot. I know we're sort of toward the ends of our time together. So why don't you pick
Oh, I pick
the next question where you'd like to wrap up. I know you've done a lot of work here, so why don't you pick where you'd like to wrap up?
I sent you some questions tonight that I've called on the parking lot that were on from previous weeks, and they're still on the parking lot, so we'll push it back to next week. Or not next week actually, because of the Mother's Day, so we'll do it 2 weeks from now. But basically, a lot of parking lot questions where people have asked things over the weeks, and we just haven't gotten around to them. So I can just start trying to knock more of those questions out. Here's one. So we had this open question about the suicide and drug use over the last year. And so we've talked previously that there have been an extraordinary amount of excess deaths. In fact, I won't go to it right now, but a lot of excess deaths, over 650,000 excess deaths at this point, probably closer to 700,000, but I haven't looked at it in the last couple of weeks. So these are excess deaths versus what you would have expected versus this same period over the 5 years preceding the start of the epidemic. And so there have been a lot of hypotheses. Well, maybe more of those deaths are due to suicide. Maybe more of those deaths are due to drug overdoses. Maybe more of the deaths are due to other things. And so we've been systematically going through these hypotheses, and what we're finding is that no, most of these deaths are either COVID-19, or if they're excess deaths that are not with a diagnosis of COVID-19, they're very likely to be misdiagnosed. So for instance, there are many excess heart attacks that have happened over the last year. And many of those heart attacks were very likely to be subsequent to a COVID-19 infection for two reasons that we know. One is that people who have COVID-19 are at much higher risk for a heart attack. So if someone has a heart attack, you would expect a certain rate in society. And so if that number jumps up dramatically over the last year, if someone has a heart attack, they just listed on the death certificate as heart attack. They're probably not going to be motivated to actually start doing diagnostic tests, particularly early last year when the diagnostic tests were so hard to find, they're so scarce. But there's other hypotheses here. The two that people were asking about were suicide and drug overdose. And so the first thing here is that drug overdose has been increasing as a cause of death for a bunch of years now. So we've started on the trend around 2018 or so. We were starting to go down a little bit, but then already by the end of January, or by the end of 2019, so before the epidemic, but then through the epidemic, definitely a number of drug overdoses was unfortunate, and this did rise. It did not rise such an enormous amount that it would explain really much at all in terms of the difference, particularly because it's compared to where we were, for instance, in 2019. It's not dramatically different. It is. I mean, it's something that's extremely concerning. But in terms of some of the excess mortality that we're looking at from COVID-19, it doesn't really describe a lot of the difference that we're looking at. In contrast, there was also variation by state. So when you break it out at a state by state level, looking at excess deaths, you can see that it doesn't correspond with the COVID-19. But when you look at suicide, so this was here. So suicides actually went down. A lot of people weren't expecting this because suicide ideation, depression, anxiety increased over COVID-19 year because of the shutdowns, because of people worried about losing jobs, that kind of stuff. A lot of anxiety, a lot of depression, a lot of suicide ideation. Suicides actually went down at a national average for some subpopulations. For instance, some rural areas, Black Americans, it affected them more disproportionately. And so there was a higher suicide rate among them. However, the net impact of suicide was actually lower than what you would have expected. And so as a result, this again is just more adding to the sum of evidence that COVID-19 is almost certainly more deadly than the CDC's statistics are telling us, rather than less deadly. And again, this is because I'm talking about the excess death data rather than the CDC diagnosed death data that they're talking about. This is a continuing conversation that's come up. I'll just say a couple more words here and then we'll end it for tonight. But basically, some people to this day still are worried that because there are false positives in the diagnosis tests, they think that means that a lot of the people who are listed as dying from COVID-19 on their death certificates were actually false positives and died from other things. But in fact, that number is much, much less than the total excess deaths that we have. And if they were false positives, you would not be expecting excess deaths based on what we've been talking about here. We talked about this a bunch over the last year, so I'm not going to really say anything more than that. But that's basically here. So this is just this other hypothesis that they've now went and investigated it. Suicides are not higher. They're not explaining the excess deaths that we're seeing. All right, Rebecca, lots more questions.
All right, so Glenn, maybe you can give us a little teaser about some of the questions and answers we'll go through when we reconvene 2 weeks from now. What are just some quick teaser. We won't go into it now, but just what are some of the questions that you'll be answering 2 weeks from now?
Oh, wait, but before I do that, I just saw that there are a couple of slides. These are the suicide things. So let me just go through it real quickly at a high level. You can see that it's not just the United States, but many other countries. This was a global analysis. I like this one from The Economist. They put this great graphic together looking at the suicide rate. 100 is what it would be if 100%, if that's what was expected. And you can see many countries were just on par. Netherlands, Peru were on par with what you'd expect. Some countries were a little bit higher. Russia looked a little bit higher, but the error bar was kind of high, so it's a little bit hard to know. But you see that the United States, the error bar was really small. We had a lot less at a national average, a lot less suicide than you would expect. Puerto Rico was higher. Some states were a little higher. New Jersey seems like it was a little bit higher than average, but other states were a lot lower. So what's most important is the United States average. But a lot of other countries also had lower. Chile, Estonia, New Zealand, England, etc. So the big question, suicide, I think that punctuates it. But getting into some of the other questions we'll be talking about, this one is one that's come up, looking at vaccines. Can people who get vaccines still get severely sick and die from COVID-19? Unfortunately, the answer is yes. So I wanted to go into that in a little bit more detail. People have been asking about that. So there, we do have some good data about that. A bunch of questions. I don't have them here in any specific order though. So why don't we wait till 2 weeks from now and we'll come back to
That's a
answer
good
some.
idea. All right, we'll keep that teaser to ourselves and we'll reconvene 2 weeks from tonight. Everybody be safe, be well. Those who are celebrating, those who are mothers, happy Mother's Day. And everybody, again, be safe, be well. Thank you, Glenn, for all of your preparation, for answering our questions,
Thank you.
for always being our tour guide. We appreciate
Thanks everyone.
it.
Bye-bye.
Take care.
Thank you.
Happy Mother's Day.
Yep, you too. Bye-bye.